Good day. This is Oscar Bukstein from Boston, Massachusetts, joining you, somewhere, I guess, in West Virginia or wherever you're zooming in to this presentation. Today, we're going to talk about evidence-based treatments for adolescents with substance use disorders and where we really stand in terms of these evidence-based treatments. I was asked to submit a mini biography. I think you have a slightly more detailed version in some of your materials. As you see, I've been around and in your neck of the woods as well. I was at the University of Pittsburgh for almost 30 years. Here are my potential conflicts. Currently, I'm employed by Boston Children's Hospital, where I'm Director of Outpatient Psychiatry Services. My only conflicts really these days are intellectual property. I have edited books by Routledge Press. I have a sole author book by Guilford Press, and I contribute to Up to Date in adolescent substance use disorders and adult ADHD. Well, let's get started in talking about substance use disorders. This graph really shows you that unlike really adults, we have a developmental context to adolescents and, for that matter, young adults who use. You see a gradual increase in most drug use. Here we have alcohol use, binge alcohol use, marijuana use, and they're very much parallel lines. They go up steadily through adolescence. They peak in the early 20s and then generally go down. And that's for the entire group of adolescents. Some don't go down, and certainly we're concerned about that, hence the reason for intervening early. We want people to be able to not proceed into having problems with adulthood. There we go. See, so it increases a lot and then decreases almost as quickly. Now, I wanted to show this slide because we're going to refer to it later. And this is important to know because it's the importance of perceived risk in terms of adolescent substance use. It's really, availability does not influence use a whole lot or change the use a whole lot. What does is perceived risk. And you see here that it's inversely related to use. In periods where perceived risk is high, use is low, and where perceived risk is low, use is high. And so that's one of the targets, not only in treatment, but also in prevention, is to increase that perceived risk. Well, we have to consider a number of factors when we distinguish adolescents from adults. There's, of course, developmental factors, physical maturity, socialization, executive function development, that is decision-making, reward sensitivity, these sorts of things, psychiatric comorbidity, a little bit different in adolescents. And finally, although adults certainly are part of families, kids are usually dependent members of a family system. Also, their peers mean quite a bit more to them than generally they do to adults. So when we talk about evidence-based treatments, and what I'm going to be doing here over the next 50 some odd 60 minutes is talking about what the research shows are evidence-based treatments. But I want you to understand the research. First of all, what are the outcomes? What do these treatments do? Obviously, since we're treating substance use disorders, we want to decrease substance use. And particularly in the United States, we have the goal of abstinence. And just about all the studies that we're going to be talking about deal with abstinence as an outcome. Well, it's a nice aspirational outcome, but it may not be a great outcome for reality, for kids in reality. That is, kids, despite our little graph there, many of them go on using, maybe not at an abusive level, pairing level, but they use nonetheless. urine drug screens to make sure that what they tell us in terms of their abstinence or drug use is on the level. And finally, and this is receiving more and more attention, substance use is not the only necessarily the only outcome, particularly if we're looking at a range of substance abuse outcomes. We want to see the adolescents become more functional in a number of different domains. The substance use domain, obvious, but also psychiatric symptoms, family functioning, school and vocational functioning, social competency and peer relations, their use, adaptive use of leisure and recreation activities, and finally, medical problems, which admittedly aren't as much of a problem as they might become with steady use in adulthood, but nevertheless can be impacted by substance use. And when we begin to define what kinds of interventions that we have, particularly psychosocial interventions, they're very much domain related. And when I say domain, there's the motivational domain, interventions that affect motivation, brief treatment, which is usually affects motivation, family treatment, family therapy, skills-based therapy, such as cognitive behavioral therapy, support, just giving adolescents the support they need, and that might be educational support, it might be leisure time support, the availability of ways in which they can socialize with peers that don't involve substances. And finally, resources that allows them to attend treatment or do well in a number of different domains. Well, how do we know if a treatment works? Well, in treatment studies, generally, we're going to compare our active intervention, family therapy, CBT, we'll talk about those, with a comparison group. Sometimes the comparison group is no treatment, kind of a waiting list. Sometimes it's treatment as usual, which is not always well defined, but what it's defined as is it's not anything like the experimental treatment. And finally, a comparison with active treatment. And that may be an active treatment that is more or less well supported by the evidence itself. We want to know certainly we want to know if one treatment is better than the other. We want to know response rate. That means the number of subjects reaching a predetermined outcome. And I've told you abstinence. That is the number of kids who reach abstinence and maintain abstinence for a given time. That's one of our goals, and that's something that we measure. We also measure something called effect size. And I'm not going to go into the statistics of this, but suffice it to say it describes the robustness, the level of effect. And in a comparison between in this case, two different treatments, our experimental treatment and our non-experimental treatment. There's a small effect size, that's little, and that's defined as lower than 0.4, a medium effect size 0.4 to 0.6 or 7, and finally a large effect size is 0.7. Small effect size may not be clinically significant. So you may have a statistical finding that there is a difference, but it's so low, we'll review this in a moment, it's so low that it probably isn't something that we would notice clinically. So we'll review that. Psychosocial interventions, let's talk about those. Motivational interviewing is basically really comprises the majority of what we call brief treatments. Just a little bit about motivational interviewing. I think most of you probably have heard about it. Client-centered directed method for changing intrinsic motivation. And we've had a lot of work done with adolescents, not only brief treatments, but as part of more expansive treatments. There are adaptations from the checkup, that is a one-time brief treatment by a lot of times a medical professional with an assessment plus a feedback. There's motivational enhancement therapy, which is basically a longer kind of 8 to 12 sessions of of different interventions that are tied together by motivational enhancement. And finally, behavior change counseling. Probably this comprises most of motivational interviewing, brief negotiation, often done in medical settings, but can be done for adolescents with substance use disorders. Well, we define brief interventions in a certain way. These are 1 to 4 sessions. They can often be prevention or early in treatment, or in cases of mild severity, it can be a lead-in into more expansive interventions, kind of greasing the motivational wheels, as it were. And as I mentioned, they're based on MI interventions. Many of you have heard of SBIRT, screening, brief intervention, and referral to treatment. And this is something that can be done in a host of different settings, such as primary care or primary mental health, in order to, for some kids who have a lower severity, to be exposed to the brief treatment, but a referral for more intensive treatment for kids who need that treatment. Now I'm going to begin to be talking about some of the studies of studies, meta-analyses, which are basically looking at common elements across different studies. It allows us to have bigger sample sizes and look at which have common outcomes. In this case, 24 studies within 19 randomized clinical trials. And all of these studies were pretty small, but they showed that the D, remember this is the effect size, was 0.27. Think about that slide a few minutes ago, and you'll say, well, that's a low effect size. That isn't very much. But you have to understand that these therapies were compared generally with another active treatment. It's hard to show a difference or much of a difference. There is a difference here between active treatments. Also significant is that the effects, at least in this meta-analysis, have persisted for a year. Cognitive behavioral therapy, and this is a skills-based therapy, enhancing coping, problem solving, and decision-making related to substance abuse. Teaching skills how to cope with cravings, how to avoid high-risk situations, how to improve interpersonal relationships so they are more rewarding, they are more reinforcing rather than depending on substance use to manage those situations. Similarly, improve communication, anger management, mood regulation are all part of the set of CBT skills. And oftentimes, the relationship is not just with substance use, it's with risky behaviors in general, such as sexually risky behaviors, which are often associated with substance use disorders. The conceptual framework is a behavioral one, that is understanding ABCs, that is antecedents, behavior, and consequences, understanding triggers, having plans for when you're exposed to triggers, being able to conduct a functional analysis of your behavior, finding what triggers seem to trigger what substance use behaviors that you have. And so that's important to do. That's an important skills for people who want to avoid having to use substances need. Family therapy, here's another major area. And most of these are called ecological models, which means basically they're done in where the kid lives. And the active ingredient is the interaction between family members rather than the interaction between a therapist and a patient. And there's a host of different evidence-based treatments: behavioral family therapy, functional family therapy, brief strategic family therapy, multidimensional family therapy, multisystemic family therapy. And I'm not going to go through the distance. You can certainly look these up. They differ. Some are more behavioral. Some functional family therapy is used for other problems such as juvenile delinquency, as is multisystemic therapy. Oftentimes they do have common elements. For instance, engaging family members in treatments, increasing communication between the adolescent and parents, parental monitoring skills and supervision skills, and finally, negotiating rules and consequences. Very important. Well, let's look at family therapy and the results of family therapy. In this particular review, actually 2 reviews in 2014 in 2018, looked at 24 clinical trials involving more than 2,000 kids. Family-based treatment versus treatment as usual or manualized therapy. We find a effect size of 0.2. Again, small effect size. Versus alternative therapies, in particular, 0.26, about the same. However, versus control, 0.7, which is which is on the bottom level of the large effect size. Why is that the case? Well, in the case of in the case of control therapies, there's no active treatment that they're comparing. That's versus no treatment. The rest are compared with some sort of treatment. The treatment may or may not have elements of evidence-based treatment, but its treatment does the same. Multidimensional family therapy is probably the most studied family therapy. In this particular review, it looked at 5 studies, but there's a number of different studies. And if you look at this, you find that indeed the effect sizes are about the same, 0.24, 0.28, 0.27 here, 6 months. Substance abuse severity a little bit higher, but probably not even reaching from small effect size to large effect size. But again, these are comparisons with some level of active treatment, either treatment as usual or a defined evidence-based treatment. Functional family therapy, a lot here. And we see the same thing here, functional family therapy versus control. And this is random assignment, gets into about a moderate effect size. Here, non-random assignment, and we don't want non-random assignment. Randomized clinical trials is for a reason. This is what happens when you do this. And in fact, this is judged to be non-significant, even though it's a high effect size. And so you see, so alternative treatments here, active treatments, does pretty good for a random assignment, which is generally felt to be the gold standard. You have a still a low effect size, but inching toward moderate effect size. And here you have probably something that gets into the high level of effect size. Again, non-random assignment. Here, I'm not going to spend a lot of time, but you see that really these are p-values. And here, this is a treatment with well, different types of treatment. But one of the things that you see is that for CBT, you probably get the best result, the one significant p-value in long-term treatment. That is, CBT is not something that you put together for 3 sessions, although there are versions of it. It may be better something that you do for 8 to 12 or more sessions. Contingency management training. Here is something that probably doesn't get as much press as it really should, and it's often thought of as an adjunct therapy. We're going to talk about that in a few minutes. It involves giving motivational incentive or rewards, either vouchers, payment, prize drawing. There's something called the fishbowl where you, a person who comes to treatment, that's what you can get a reward for that, attendance. You can get a reward for a negative urine, a screen, and this is often done contracting with parents who may deliver the rewards themselves. But also it has escalating rewards with compliance. So the more you come, you say you come for each a session that you come, you get a greater reward. Or for each successive negative urine drug screen, you get a reward. This does quite nicely, and at minimum, it does improve compliance. It generally pays for itself because people come to treatment more, hence you can bill more. And again, it's something that's often used as an adjunct with other treatment. Well, these are kind of messy slides, but let me tell you about it. This is from these reviews in 2014 and 2018. And the author really defines this as probably efficacious. That means the evidence is pretty good, or possibly, meaning generally there are not enough studies and it's not unequivocal findings. Here we go. CBT, CBTG is CBT in group format. CBTI is in individual format. Sometimes you can get a group, sometimes you can't. The family therapies, particularly this, MST, brief strategic family therapy, these are probably, in this case, this is possibly efficacious. MST, brief strategic family therapy, and actually multidimensional family therapy are probably efficacious or efficacious. Family-based treatment, behavioral, again, probably efficacious. Motivational interviewing or motivational enhancement, again, probably efficacious. So these, when we say probably efficacious, these are the types of interventions that you might want to consider including in your treatment offerings. Integrated treatments, oftentimes investigators have said, or clinicians have said, well, if one evidence-based therapy works, what about two? What about adding on to them? For instance, this is one that SAMHSA offers. You can get their online, you can get their manuals, motivational enhancement therapy plus CBT in a 5-session version, a 12-session version. So you have motivational kind of degrees the wheels and then a skills-based on top of that. Here is one where they have this, plus they add a family-based treatment. Here is one that's actually has, these two have evidence where they have a family-based treatment plus a contingency management. So this is an evidence-based combination that's probably efficacious. Here we add all of them: motivation, family, contingency management. Again, the top. They're not incompatible. Motivation, contingency management are not incompatible with family. There's well-established standalone treatments. We've talked about that. And here are some other studies. Here's a culturally tailored version of CBT group, which is equivalent to both the regular CBT group, and the individual. Here is another type of CBT within this type of a treatment. And it is actually superior to usual treatment or family-based, this type of family-based treatment. We have, these are probably efficacious. So I think what the upside about this is that there are a lot of family-based treatments as well as CBT treatments that are either efficacious, probably efficacious, or at the very least, possibly efficacious. I think you're going to receive a talk by Dr. Kelly sometime in this series, and he compared a step work program to motivational plus CBT and found that they were equivalent. However, there was really not, and they were equivalent and they had no substance use effects, meaning they were about the same in terms of substance use, and with very little in this particular protocol. We have another one where we compare an evidence-based treatment with this motivational CBT plus family based treatment. So as we saw that in a previous slide, this is probably efficacious. This basically goes the same, they say same thing. Some of the studies are better than others. Some of the studies show different. But I think on the whole, we have a host of different efficacious treatments to choose from. Multi-component here, some of the same thing, family plus contingency management. Definitely at least equivalent to another active treatment as usual. We have this 3-part treatment of motivation, CBT, family, actually 4-part, plus contingency management. And as you might expect, the more you add, the more components you have, the more superior it is to individual components within that multi-component treatment. Dr. Kelly's 12-step work is believed to be possibly efficacious, limited only because it's the only study of its kind. And, you'd have to replicate that to really get up there in terms of efficaciousness. Now, the AHRQ, many of you are aware of this. This is, they do Agency for Healthcare Research and Quality. It does reviews, systematic reviews, and it grades the evidence. And they recently did one. Actually, we were involved in the American Academy of Child and Adolescent Psychiatry in promoting this, in which they looked at the brief interventions, they looked at the more expansive interventions, and they looked at a wider age group. And they did a systematic search. They got every article they could. They looked at all the specific studies. They graded the evidence, and it came up with these these conclusions. Compared with treatment as usual, brief MI increases the likelihood of abstinence from alcohol, reducing both heavy alcohol use and overall days of use. So brief MI does have a role, seems to have a role. When we say brief MI, we're talking about 1 to 4 sessions. However, brief MI does not appear to decrease cannabis use among adolescents. Remember, brief. MI may decrease problems related to substance use, such as school work or getting into trouble. And here's that part that I mentioned before. We have to have wider domains. We may see generally cannabis use continue, cannabis use continuing at close levels, but the kids getting better in terms of their functioning with family, school, and the like. And we might miss that if abstinence or urine drug screens are only outcomes. Family therapies may be the most effective in reducing both heavy days of alcohol use and overall alcohol use. So definitely with involved in alcohol, family therapies work. And generally the feeling is that they're probably the single most effective psychosocial intervention for adolescent substance use disorders. Opioid disorders, and I know this is important for folks, well, really everywhere, certainly in Appalachia and West Virginia. Buprenorphine, Suboxone, buprenorphine and buprenorphine naloxone are more effective in short-term management if they're tapered over a longer period, which means really, and we really only have 2 studies to go on, but they were both positive in showing this. If we look at the adult literature, it shows the same thing. The longer we keep up buprenorphine, the better the population. It's actually not just a tapering agent or a short-term agent. It's actually a long-term replacement. Now, it can be used for those things. So, I went over all of these types of discussion of all these interventions. What does it mean? What does it mean? Well, different evidence-based interventions have similar efficacy. whether we're talking about really the major players for intensive intervention are family therapy and CBT. MI and MET, not enough alone. And two, we get the feeling that the more components that we use, the more that target those different domains, family, skills, motivation that I mentioned, the better off we are. Now, admittedly, there's a limit to what you can do, to limit to what families want to do. And, at some point we'll have enough lessons to tell us how much is an adequate dose. How many sessions do kids have to go to that you're going to see a substantial improvement? And what is the cost of additional? Do kids just drop out after so many sessions, or families lose interest, or we reduce our benefit by going that longer? I'm not sure. We need to answer those questions. Now, I wanted to show you an example. This is from the lab of Tony Spirito at Brown University. And he recognized that all these domains to direct at adolescent substance use disorders are valid, that they work, evidence. What if you put them together, or what do you put them in modular form? What does modules mean? It means there's a whole set of different things. There's family-oriented modules, there's skills-oriented modules and CBTs. There's some that deal with a psychiatric comorbidity. The object is you would use only the ones you need. Not every kid has a problem with their family. Not every kid is a poor problem solver. So you design it individually. And I thought this was interesting because this is one giant treatment intervention that consists of various modules. I wouldn't expect everyone to do everything, but it's pretty complete. And if you see it, you look at goal setting, you'll see some CBT, problem solving, cognitive restructuring, increasing healthy events. Some of these are a part of treatment for mood disorders, affect regulation, communication training. Functional analysis of not just substance use behavior, but dangerous behavior, guided imagery, managing aggression. It's a big part of, whether you're talking about aggressive behavior, depression, anxiety, these comorbidities, psychiatric comorbidities are very important to tackle for ultimate improvement. Some of these really reinforce, if you are depressed and you feel better using substances, you're going to use substances unless you have an intervention that changes that reinforcement. Individual substance-specific module, motivational interviewing for alcohol or drug use, coping with cravings, planning for years, relapse prevention, again, CBT related, family modules. Some of the things that we related that family interventions consist of: family problem solving, family communications, increasing their interactions, and behavioral contracting. So as you see, you can get a lot. And while his treatment hasn't, his modular approach hasn't been adequately treated, he looked at actually the group he ended up looking at was kids with suicide, depression, and substance use. So a lot of that, made sense given that type of comorbidity. But suffice it to say, what happens if you use a modular approach to general people rather than give them everything out of all four modules? You are more selective as per their needs. I'm going to talk a little bit about medication interventions. It's something that we've been a part of during the course of my career. There's various types of things that medications can do. One is craving reduction and blocking strategies. That's what naltrexone does, and it's probably the best supported therapy. It's an opiate antagonist, and it blocks positive reinforcing effects of alcohol and opiates. There is two small studies of adolescents which seem to show very modest effects, but effects. Acamprosate, this is a medication for alcohol dependence. And there was a small study, a double-blind study in Europe, probably about 20 years ago, that was positive. But it's a difficult medication. It has to be given 3 times a day. It's hard enough to get adolescents to use one medication a day, much less multiple medications. Substitution therapy. We talked about buprenorphine a bit. It's an opiate agonist, a slight antagonist. It can be prescribed in the outpatient setting by a non-psychiatrist. The efficacy in adults is really unquestioned. But there are 2 controlled trials in adolescents for essentially withdrawal. This was not long-term treatment. It lasted up to several months. I think 6 months was the longest, and it found clearly that buprenorphine was better than placebo. So it does work for adolescents. We've used it quite a bit for adolescents with opiate use disorder. What about comorbid depression? Now, obviously, many kids, adolescents with substance use disorders also have psychiatric comorbidity. Depression, ADHD, bipolar disorder, and anxiety disorders. Now, I'm not going to show you anything with anxiety disorders because surprisingly, there are none in adolescents. I never got that far, but it is interesting. One of the reasons is many of them also have comorbid depression. They seem to be defined more. There are 3 double-blind placebo trials of depressed kids with substance use disorder. Paula Riggs had one, well, not quite 15 years ago with fluoxetine. Now, she improved depression outcomes, but there was no difference between placebo and active drug in terms of substance use outcomes. Jack Cornelius and I was up in Pittsburgh, looked at fluoxetine in adolescents and young adults with alcohol use disorders. And Bob Findling, when he was at Case Western, similarly looked at a population of adolescents. Both of these studies were negative. They did not find a difference. Both groups, both the placebo group and the group taking fluoxetine in each study, did get better. They both got better, but there was no difference at the end. So 1 positive study, 2 negative studies, a number of open label studies. Interesting enough, and I go back more than 20 years, Barbara Geller, who just passed, did a study which was the first lithium study in any bipolar adolescent population. And she found that there was improvement not only in psychopathology with lithium, but improvement in random urine screens, but not in levels of reported use. Now, this is very suggestive. Bipolar disorder is a disorder that has a very high level, where you're looking at adolescents or adults, a very high level of substance use. But also we're reminded that the levels that random urine screens, we do those because we can't always trust in reports of use. This ADHD, a number of different studies. Dr. Riggs studied a double-blind placebo trial of Pemolin versus placebo. Pemolin's an old stimulant that was taken off the market soon after she completed her study. That was a negative study. Paula did another study, and we were a part of that, a multi-site study by the NIDA Clinical Trials Network, where she looked at oros methylphenidate in adolescents, mostly with cannabis use problems and ADHD. She found no difference in reported substance use and ADHD symptoms, self-report. If you look, however, at parent report of ADHD symptoms, there was a significant difference. She just chose the wrong outcome. Probably parents have a greater sensitivity to change in ADHD symptoms. Kristen Thurston looked at atomoxetine. It was a negative trial. Both groups in all of these studies both groups, placebo and active medication groups, did both improved. Both improved. However, there was no difference between the two. Claudia Zabut in Brazil did a study where she looked at an methylphenidate compound in a group, and she actually found a difference, both in ADHD and substance use disorder. She did find a difference. It was a small difference, but nevertheless a difference. So what does these studies of comorbidity, what is the evidence base for them? Well, there's little evidence to support that the treatment of comorbid psychiatric disorders affects substance use outcomes. In other words, if you treat comorbid depression alone, if you treat comorbid ADHD alone, or the substance use doesn't get better. You have to treat the substance use specifically. But there's some evidence, not conclusive, that it still helps the disorder that is targeted. For instance, antidepressants, some studies show that they do work. They do, that their improvement is greater than that of placebo. And similar with ADHD medicines. So because they don't seem to cause any untoward side effects, any problems with these things, it's compelling to at least try them in cases where you have comorbidity. Let's look at, well, let's talk about the future a little bit, because I think it's important. These are areas that really we need to study more. And frankly, you know, many of the studies that occur now are using those same evidence-based treatments. So we've identified a number of evidence-based treatments. We use them in different populations, different age groups, different comorbid groups, different racial ethnic groups. That is important because I think we know they work. We want to see about aftercare or booster sessions. All these treatments are time limited. You know, you do your 12 sessions, I'm making that up, but you do your 12 sessions and that's it. And they measure your outcomes at the end of treatment, maybe in 6 months and a year, but that's it. You don't necessarily get more treatment. When I was down in Houston, I came acquainted with alternative peer groups. And these are programs that really focus both in group settings and recovery high schools, which are really all over the country. But these alternative peer groups appear to be primarily in Texas, and particularly in the Houston area, where basically they do everything. There's some other evidence-based components, but mostly it's peers doing pro-social things, activities together, and understanding they can have fun, talking about their problems, less structured. But I have some colleagues, in fact, Dr. Kelly was very interested in studying alternative peer groups as a specific treatment for adolescent substance use disorder. Many of you have heard of acceptance and commitment therapy, particularly with adults. This is something that I think there are pilot studies, but really something that needs to be looked into, maybe similar in some respects to motivational interview. Adaptive interventions. What do I mean by adaptive interventions? Well, there are some studies, a colleague of mine, Yifra Kaminer, who just retired from the University of Connecticut, these are staged treatments. So what would happen is you would go into a treatment with, and it might be a comparison, it might not, of say family therapy. And if you got better, great. You know, maybe you had aftercare, but you got better. The people who didn't get better then did something else. Maybe it was CBT. Maybe it was medication. In other words, at each point, and there's some similar studies like STAR-D in adults with depression, where there are different levels of treatment. And that has ecological validity because that's what we do in real life. we give a kid a treatment, maybe intensive outpatient program. If they don't do well, maybe we put them up to residential treatment. Maybe we put them in family treatment. We do it in steps. Finally, different doses. I mentioned before that this is important to understand that people need to understand what's the least we can go with. What's the least that we can go with to be effective? What is the threshold? We don't know it. And it's probably different for different populations. It may be that certain adolescents with certain characteristics can have brief treatments and do quite well. We don't have to put them in 90-day rehab or IOP. Or certain populations do better in family therapy than cognitive behavioral therapy. In fact, there's some data that seems to suggest that. For instance, if you have a motivated adolescent who wants to get well, and particularly if their family is not too impaired, that you might want to give them CBT. If you have a kid who's very resistant and difficult, maybe you want to give them family therapy. New populations. We need to do much more in the opiate use disorder population. I don't need to tell many of you, how important this is. Through most of my career, opiate use disorders became the second most common drug of use next to marijuana in treatment sessions, in treatment populations. Different ages, I mentioned that, different racial and ethnic groups, different comorbid psychiatric disorders. There's a lot of those sorts of things. Finally, with the most treatment-resistant populations, the most difficult, we need to figure out, is there something we can do for this group? Because these are going to be the scourge of not just treatment professionals, but society as a whole. They're going to, they are the criminals. They are the folks who really affect society in a profound way. I mentioned before when I talked about outcomes that substance abuse outcomes are not the end all. We need to look at other domains of functioning. We also need to, in order to look at benefit from combinations of studies, remember those meta-analysis, we need to develop uniformity of outcomes. Well, to a certain extent, they're already there. Urine drug screens are common across studies. Mostly the the abstinence is based on timeline follow back, which is a method of looking at use over the past 30 or 60 days. Dig data, there's my one typo, and that should be big data. That is, hopefully, as we get better ways of getting data in regular treatment programs, we can look across big populations and divine what works. Finally, as a psychiatrist, I'm very interested in the interaction of psychiatric symptoms. And we can collect data using our cell phones and look at momentary data capture and look at moment to moment how kids feel and how it contributes to their substance use, their cravings, etc. Those are the types of trials in the future that will be important. Many of you may have strayed into more science, and you find out that reward and reinforcement, the more we know about the brain and how it works, the better we're able to figure out how to replace the reward and reinforcement of substances with other rewards and reinforcement. It's more pro-social, more adaptive. Executive functions. This relates in some ways to ADHD. In some populations of adolescents with substance use disorders, we find that the level of ADHD is upwards of 50%. So these kids have problems in making the best decisions because of their deficient executive functions. Hence, maybe there are specific interventions that target those that might be effective toward reducing their substance use disorders. I mentioned comorbid psychopathology quite a lot. We often talk about depression, anxiety, ADHD, et cetera. But there are other things that I think are important. Mood regulation is a big one. We really don't say, oh, this is a study of adolescents with substance use disorders and mood regulation problems. We say depression, we might say anxiety, we might say actually bipolar disorder. But mood regulation is important and often really interfaces with executive functions in adolescents who are at highest risk for substance use disorder. Finally, we really need to understand the process of treatment, that is therapist factors, non-specific and specific factors that go into treatment success. If you remember, we didn't have big effect sizes. There wasn't a lot of difference between our experimental treatment and active treatment. Why is that? Because therapist factors, non-specific factors are very important for treatment, more important than we like to think of. But that's good because not everyone is trained in CBT, not everyone is trained in one of these family therapies. So in a sense, something, or at least some things are better than nothing. Thank you very much.